Chapter 29 is going to be on the normal anatomy that we see on panoramic images. The learning objectives for this chapter will be to define the key terms associated with normal anatomy on panoramic images and to identify and describe the bony landmarks of the maxilla and surrounding structures as viewed on the panoramic image. So why are we doing this chapter, right? We need to be able to interpret the panoramic image and identify normal anatomic landmarks. The dental professional must have a thorough knowledge of the anatomy of the maxilla and the mandible as viewed on a panoramic image. Also, we need to be able to examine the airspace images and the soft tissue images that might be present on our panoramic images. So the normal anatomic landmarks that we see are going to be bony landmarks of the maxilla and the surrounding structures, the bony landmarks of the mandible and the surrounding structures, the air spaces that are seen on panoramic images, and the soft tissues that are seen on panoramic images. So the first thing we're going to go through are the bony landmarks of the maxillary areas, as you can see here shown on this image. We're going to go through each one of these numbers and say what it is and how to identify it. Those structures are the mastoid process, the styloid process, the external auditory meatus, the glenoid fossa, articular eminence, lateral pterygoid plate, pterygomaxillary fissure, maxillary tuberosity, infraorbital foramen, and the orbit. The incisive canal, the incisive foramen, the anterior nasal spine, the nasal cavity, the nasal septum, the hard palate, maxillary sinus and floor of the maxillary sinus, the zygomatic process of the maxilla, the zygoma, and the hamulus. So number one here you can see is the mastoid process, and it is number one marked on the illustration as well. It is a marked prominence of bone located posterior and inferior to the temporomandibular joint. On a radiograph, it shows up behind and lower than the TMJ. It appears as a large, rounded radiopacity located posterior and inferior to the TMJ area. And you'll never see it on an intraoral radiograph. You will only ever see this on a panoramic. Number two on this image is the styloid process, this thing right here. It is a long, pointed, and sharp projection of bone that extends downward from the inferior surface of the temporal bone. So the styloid process is on the temporal bone. It appears as a long radiopaque or white spine that extends from the temporal bone anterior to the mastoid process. So we've got the mastoid process here, and then as we move anterior toward the front of the face, we see this little styloid process or pen-like projection as it comes forward. All right, number three is the external auditory meatus, this one right here. This is a hole or opening. Anytime you see the word meatus, it means an opening. In the temporal bone, it's located superior and anterior to the mastoid process, right? So above and forward from the styloid process back here. It appears as a round or ovoid radiolucency anterior and superior to the mastoid process, and it is not seen on intraoral radiographs. This is the tiny hole where your ear actually funnels sound through so that it gets into your in towards your brain, right? So this is the ear canal or the external auditory, meaning sound, meatus, meaning hole. The glenoid fossa. This is a very important little fossa, all right? This is a concave, I'm sorry, it's number 4. It's right here. This area, this concavity right here it's a fossa, right? Which means it's a depression in bone. It's a concave, depressed area of the temporal bone. It appears as a concave radiopacity superior to the mandibular condyle. It's not seen on intraoral radiographs, only on a panoramic like this one, or maybe a cephalometric external. And it's very important because this is where the condyle of the mandible actually kind of rests and hangs out. And so whenever there's an issue with this fossa, maybe the patient has some type of difference in the way that they're shaped. And so if patients have, variations or less than perfect or ideal situations going on with their glenoid fossa, then they're going to have TMJ issues, right? And so this is a very important thing when you're checking for EOIO to see if they have clicking or popping or pain in their TMJ. Then you are essentially you're placing your fingers right here next to this glenoid fossa, and you are feeling as that condyle slides it hinges open and it glides forward within this fossa. All right, so the next one is articular eminence. It's number 5, and it is a rounded projection of the temporal bone located anterior to the glenoid fossa. So there's the glenoid fossa, number 4, and then at the very front is the articular eminence. It appears as a rounded radiopaque projection of the bone located anterior to the glenoid fossa. You don't see this one on intraoral radiographs. Number 6 is the lateral pterygoid plate. It is a thin, wing-shaped bony extension of the sphenoid bone located distal to the maxillary tuberosity region. So it looks like this thing right in here, right? This is the part where the hamulus comes off the bottom, right? We saw that one on our intraoral radiographs. But anyway, number 6 is the lateral pterygoid plate. I see this one missed a lot when it comes to identifying structures on a panoramic. So don't forget that right behind the maxillary and the palatal bones, there's this sphenoid bone, and it's going to show up on some of our x-rays, okay? So the lateral pterygoid plate, it appears as a rounded radiopaque projection of bone distal to the maxillary tuberosity region. Typically, we don't see the lateral pterygoid plate on an intraoral radiograph. Number 7 is the pterygomaxillary fissure. This one, you kind of have to break it apart to figure out where it is. So ptera or pterygo, right, which is going to mean for us the pterygoid plate, which is on the sphenoid bone, right, and maxillary being the maxillary bones. So it's where the sphenoid bone or the the lateral pterygoid plate of the sphenoid bone actually articulates with the maxillary bone. So this is the fissure where those two connect. It is a narrow space that separates the lateral pterygoid plate and the maxilla. It appears as a rounded radiolucent area between the lateral pterygoid plate and the maxilla. It's number 7 right here. It's this little sort of teardrop shaped or ovoid shape that is where the lateral pterygoid plate and the maxillary bones touch one another, right? It's where they meet up. And typically the zygoma is often over it, so you don't get to see it very well, but every once in a while you will. So if you see a little radiolucency right here above where the lateral pterygoid plate is, then that's what this is, the pterygomaxillary fissure. And sometimes it's bordered, no, I'm sorry, it's always bordered by this maxillary sinus and the lateral pterygoid plate. So you'll see it right here in between those two structures. Number 8 is the maxillary tuberosity. And this one is on a panoramic. It's kind of hard to distinguish between the maxillary tuberosity and the hamulus, right? So number 8 over here is the maxillary tuberosity, and the hamulus is over here on number 21. So don't get those confused. It is a rounded prominence of bone that extends posterior to the third molar region. It's a rounded radiopaque, right, white bulge, again, distal to the third molar region, and it's also viewed on intraoral radiographs, right? On our maxillary PAs, we see this one. Sometimes you even see it with your bite wings. But anyway, you can see it on your intraoral ones, but don't get it confused with the hamulus. All right, the infraorbital foramen. This is a pretty important foramen. It's number 9 right here on this radiograph. We're not talking about this blue blot like right here. We're talking about the little tiny dark hole, this foramen that number 9 is pointing to. It is the infraorbital, which literally means below the eyeball, right? Foramen, which means a hole. That's what it is. It's below the eyeball hole. And it's a hole or bone in bone inferior to the border of the orbit. It appears as a round or ovoid radiolucency inferior to the orbit. It literally tells you where it is. So it's not seen on intraoral radiographs, right? We only see it in panoramic or extraoral. And it's a very important little foramen because when we numb patients up, we are using the infraorbital foramen as kind of a guide and kind of tells us where to go. And it's also, remember when we were talking about the some of those other structures for the lateral fossa, which is sometimes called the canine fossa that we see, and we use the infraorbital foramen as like a guide. So it's from the infraorbital foramen down and slightly anterior is where you'll feel that lateral fossa, which is the little depression right in front of where your canine is on your alveolar process. But anyway, the infraorbital foramen is a little tiny below the eyeball hole. All right, number 10 is the orbit, or the hole where your eye goes, right? The bony cavity that contains the eyeball. It appears as a round radiolucent compartment with radiopaque borders located superior to the maxillary sinuses. So anytime you see it's a concavity or it's a concave cavity, right? A body cavity, not like a tooth cavity. It's going to be bordered by those radiopaque borders, right? Because it has that cortical bone that the cancellous bone sits inside. So the borders of almost every cavity or fossa or foramen or anything like that is going to be bordered by cortical bone. So here it's going to appear as a round radiolucent compartment with radiopaque borders located superior to the maxillary sinuses. We do not see this one on intraoral images. Thank goodness we can't see their eyeballs on their intraoral radiographs. On most panoramic images, only the inferior border of that orbit is going to be visible. You probably would have a very strange panoramic if you saw the entire orbit. Number 11 is the incisive canal. It is the passageway through bone that extends from the superior foramina of the incisive canal to the incisive foramen. Remember we talked about the inside of the nasal cavity having those two small dots, the superior foramina, and then they join and then they come out from the incisive foramen. Well, the canal right there, that is what number 11 is showing you. It appears as a tube-like radiolucent area with radiopaque borders that may also be seen on intraoral radiographs. This incisive canal can also be called the nasopalatine canal. A lot of the times the word incisive can be swapped out for the word nasopalatine. I like nasopalatine better myself because it describes where the heck it is, but I'm not really sure where the incisive comes from, but yeah, so this number 11 right here is the incisive canal. Of course, number 12 is the incisive foramen, right? Where that canal enters or where it exits the nerve through. And so it is an opening or hole in bone that is located at the midline of the anterior portion of the hard palate, directly posterior to the maxillary central incisors. And in soft tissue, it is covered by the incisive papilla, right? So the appearance here is a small ovoid or round radiolucency located between the roots of the maxillary central incisors. It can also be seen on intraoral images. It's also swapped out for the word nasopalatine, at discretion. So number 12 here, you can see it right between these the two apexes of your maxillary central incisors. You can see that little roundedness. That is the incisive foramen or the nasopalatine foramen. Okay, the anterior nasal spine. It is that sharp, bony projection of the maxilla, and it's located at the anterior and inferior portion of the nasal cavity. So right at the bottom of the nose, there's that little sort of thing that sticks out, and it's shaped like a V-shaped radiopaque area located at the intersection of the floor of the nasal cavity and the nasal septum. You can see it on intraoral images. I know we've talked about that. And it shows up right here, number 13. Now, don't get confused with this little projection up here and number 12, okay? Because number 12 is the incisive foramen. Number 13, this one's going to be a radiopaque. Number 12, down here in between the two, that's going to be radiolucent, right? So try to keep these separated. That 13 is that anterior nasal spine. Number 14 is the nasal cavity. I always think it's hard when there's like a big space like this and they're trying to label the whole thing. They put one little number like right here. Like it's kind of hard to guess like what the heck are we labeling right here, right? But all the rest of them have those little lines that point directly to what it is. And so if there's no line pointing to directly whatever that number is, then you're kind of looking for something bigger. But anyway, the nasal cavity is a pear-shaped compartment of bone located superior to the maxilla. You guys all know where the nasal cavity is. It appears as a V-shaped radiolucent area superior to the maxillary incisors. It can also be seen on your intraoral images as well. And sometimes it's known as the nasal fossa, right? Because it's a depression in bone. But I mean, realistically, it's a cavity. There's like stuff in here. The nasal septum. Number 15, you can see the little line pointing down to this little line, this little wall or partition right here, right in the middle of the nasal cavity. It is a vertical bony wall that divides the nasal cavity into right and left nasal fossa. It appears as a vertical radiopaque partition that divides the nasal cavity. It can also be seen on your intraoral images. Sometimes when you take a panoramic, this nasal septum is not going to always appear perfectly straight, and it might not always divide these perfectly in half. Sometimes patients have, a deviated septum, but sometimes too the panoramic, because it's not a perfect science, not everyone is perfectly fitted, and so sometimes patients aren't in the focal trough exactly where you want them, and the nasal cavity and all of that stuff is actually a little bit superior to where the focal trough really gives you a good detail, and so sometimes there is a little bit of distortion on some of these structures, and that's okay. I actually had one of these scares when I took a panoramic on my daughter. And it looked like this nasal septum. There was like a ghost image of it over by the infraorbital foramen. And I saw it and I was like, oh my goodness, like something's going on. I don't even know how she's able to breathe. And I had that moment of like parent when you're like freaking out because there could be something horribly wrong with your kiddo. And I go to my one dentist and he's like, oh yeah, you need to take her to an ear, nose, and throat doctor. And then like he wasn't the one that I normally see, and so I go back to my regular dentist, and he's like, I think she'll be fine, just take it again when you see her next time. And I was like, what? How on earth, why would I not take her to an ENT like right now? And he's like, well, sometimes these things they just show up weird. And he's like, so just trust it. Just take, wait and take it again when she's ready. And of course I couldn't do that. So I was like, no, I'll bring her in. If you think that I just need to take the piano again, like I'll just bring her in and take it. And he was like, okay, well, do whatever you're gonna do. So I bring her in like a couple days later, and I take it again, and of course it was just a distortion on the panoramic, and I took it again, and she came out clear in the focal trough, and everything was perfect, and she doesn't have a weird mass growing in her face. Um, so yeah. Anyway, the nasal septum divides the nasal cavity right in half. It's a bony wall, so it is going to be a radiopaque partition. Okay, number 16 is the hard palate. Now try to remember that the hard palate is a structure that completely covers the entire, maxillary bone. It goes all the way across. It's a bony wall that separates the nasal cavity from the oral cavity, right? And it appears as a horizontal radiopaque band superior to the apices of the maxillary teeth. It can also be seen on intraoral images. I mean, you're probably going to see something of the hard palate. Um, but on a panoramic image, this will sometimes appear a little bit distorted, or it'll appear like a ghost image because it's going to be higher than where it actually is sometimes, and that's okay. But the hard palette is going to be that big radiopaque band that cuts right across the front of your patient's face. So 17 and 18, these are both the maxillary sinus. For 17, you can see how it doesn't point at anything. And then 18 is pointing right at the bottom of this little bluish blob, and it is the floor of the maxillary sinus. The maxillary sinus itself is paired cavities or compartments within bone that are located inside the maxilla. It is superior to the maxillary posterior teeth. They appear as paired radiolucent areas located superior to the apices of the maxillary premolars and the molars. They can also be seen on intraoral images. You should definitely see these on your intraoral images. But as far as the floor of the maxillary sinus goes, that is where we see that radiopaque line, right? The edge of the sinus. And so the sinus itself, the cavity, is radiolucent, but the floor of the maxillary sinus is where we see that dense cortical bone giving us the border of the cavity, and that border is radiopaque. Okay, number 19 right there is showing you the zygomatic process of the maxilla. And just like we saw on our intraoral radiographs, it will show up as a J or a U-shaped radiopacity located superior to the maxillary first molar region. And it's also seen on intraoral images, but it is a bony projection of the maxilla that articulates with the zygoma. Don't get that confused. The zygomatic process is on the maxilla. The zygomatic process is not on the zygoma, okay? And it's right over here, number 19. Number 20 is going to be the zygoma, which we just talked about, right? It's the cheekbone, and it articulates with the zygomatic process of the maxilla. We all know articulate means that it connects to, right? It touches. The appearance of a it appears as a diffuse radiopaque band that extends posteriorly from the zygomatic process of the maxilla. A diffuse radiopaque band means that it's not as dense, it's not as bright white, right? It's more see-through. So just keep that in mind when we say a diffuse radiopaque band. And you can see it on intraoral images, as we've known. And it's going to be this area right here, number 20. All right, number 20 is my favorite, the hamlet back there. The hamulus is a small hook-like projection of bone that extends from the medial pterygoid plate of the sphenoid bone, and it appears as a radiopaque hook-like projection posterior to the maxillary tuberosity region right there, not to be confused with the maxillary tuberosity, and you can see it on your intraoral images. The hamulus is also called the hamular process, and it's located posterior to the maxillary tuberosity. It's that little dangly thing right behind. Don't get it confused with the styloid process, though. My goodness, this one over here, this is the styloid process. This is the hamulus. Not sure what happened on this slide, but those learning objectives might have gotten cut off. Anyway, so we need, for the rest of this chapter, we need to be able to identify and describe the bony landmarks of the mandible and the surrounding structures as viewed on a panoramic image. And we're also going to talk about the air spaces and the soft tissues as viewed on the panoramic image. So we will discuss the mandibular condyle, the coronoid notch, the coronoid process, the mandibular foramen, the lingula, the mandibular canal, the mental foramen, and the mental ridge. We'll continue on to discuss the mental fossa, the lingual foramen, the genial tubercles, the inferior border of the mandible, the mylohyoid ridge, the internal oblique ridge, external oblique ridge, and the angle of the mandible. So here are those structures, numbers 1 through 16. Number 1 is the condyle, the mandibular condyle. It is a rounded projection of bone extending from the posterior superior border of the ramus of the mandible. It's this big old sort of knot right there on the back of the mandible, and it's a very important condyle, right? It is what articulates with the temporal bone, and it sits in that glenoid fossa, and it is what allows us to talk and eat and chew and look the way that we do. And ask anyone who has temporomandibular joint disorder, and you will find out that your TMJ is a very, very important joint. I would say more important than your knees or your hips or your shoulders. It is a very important joint for life. Anyway, it appears as a bony, rounded, radiopaque projection extending from the posterior border of the ramus of the mandible. We do not see this one on intraoral images. You would be very unkind to your patients if you were putting your intraoral images or sensors so far back there you were able to capture this, so don't do that. And it rests inside the glenoid fossa of the temporal bone. Number 2 here is the sigmoid notch, and it is a curved depression located between the mandibular condyle and the coronoid process. This little curvy right here, that is the sigmoid notch, and it appears as a radiopaque curved depression located between the mandibular condyle and the coronoid process on the superior border of the ramus. It's not seen on your intraoral images. Don't do that to your patients. The sigmoid notch can also be called the mandibular notch, okay? But basically, it's the notch right here in between the condyle and the coronoid process, right? The little notch. I'm not sure who sigmoid is. Number 3 is the coronoid process. This is a thin prominence of bone that's shaped like a crow's beak. Who decided that? Anyway, it's shaped like a crow's beak and is found on the anterior superior ramus of the mandible. It's this thing right here. Number 3 is this little curved part. It appears as a triangular radiopacity posterior to the maxillary tuberosity region. It can be seen sometimes on maxillary molar periapical images, right? We talked about that before, where if the patient's open a little bit, then the coronoid process slides forward a little, and we see it on our maxillary molar projections. You're going to find that coronoid process is very important to you as a hygienist, and understanding the way that jaw works is going to be very important for you, because when you're trying to clean the buccal or the distal buccal surfaces of third molars, you're going to have a really hard time reaching it if your patient is open all the way, because when they open, the joint, the condyle, will hinge open and it will glide forward. And as it glides forward, that coronoid process actually glides forward and covers up the distal buccal aspect of the third molars, right? Sometimes even the second molars, depending on the person. And so what you need to do as a hygienist is have them close a little bit, and that will allow the coronoid process to slide back or glide back into where it is supposed to be, so that you're able to reach those surfaces of the teeth. So the coronoid process is one of those things that it really gets in your way, but it should be pretty easy to remember that it's there, because you're constantly having to deal with that, close a little and having them maybe slide their jaw over to the side so that you're able to access those areas of the teeth. The mandibular foramen, this is number 4 right here. You can see it's at the top of where this little line starts, right? We'll talk about the little line later. But anyway, number 4 is a little tiny hole right here. It's on the inside. It's on the lingual aspect, okay? It is a round or ovoid hole in bone. Anytime we see the word foramen, that's what it is. And it's on the lingual aspect of the ramus of the mandible. It is where that mandibular nerve enters that mandible. It appears as a round or ovoid radiolucency, which means it's a dark hole, entered within the ramus of the mandible. And it's not seen on intraoral images. It's too far back. It's too far up, right? So we only see it on our extraoral images, but we definitely see the mandibular canal, right? Okay, so the lingula. This is a small tongue-shaped projection of bone seen adjacent to the mandibular foramen. It looks like an indistinct radiopacity anterior to the mandibular foramen. It's not usually seen on your intraoral images. Lingula is a word, it's a Latin word. It means tongue. Those of you who speak Spanish are probably pretty familiar with lingua or lingula or anything like that. It's a very comfortable root word. But anyway. It's going to be right here, this little area. You're going to get like a little white patch right there around number 5, and it's diffuse. It's indistinct. I mean, they say tongue shaped. What the heck does that mean? It's kind of just like it starts here, and it's like a tongue shape, like if this were a tongue. Anyway, it happens. It's at the curve. I think that's what this is. It's cortical bone from here, and it curves around, and this area right here is just darker because it's more dense right there at the curve. The mandibular canal. This is wonderful. It's a wonderful structure. We see it on a lot of panoramic images. We see it on our intraoral images as well. But it is a tube-like passageway through bone that travels within the body or length of the mandible. It's a very important canal. And it appears as a radiolucent band outlined by 2 thin radiopaque lines representing the cortical walls of the canal. It can also be viewed on intraoral images. So it extends from here, from this mandibular foramen, all the way to the mental foramen. You'll see this line right here, this number 6. This line is the mandibular canal, and it houses the inferior alveolar nerve and blood vessels. It's a very important, it's going to innervate all of these teeth as it comes around, usually even that one. And then all the way up to the canine is where this mental foramen starts to take over. And of course, the mental foramen is next. This one is a opening, as every foramen is, or a hole in the bone located on the external surface of the mandible region and of the mandibular premolars. It appears as a small ovoid or round radiolucency located in the apical region or next to the tips of the roots of the mandibular premolars. You'll always see it kind of in this little area around where the 2 premolars appear. You can see it on most of your intraoral images, your PAs. You'll see it a lot. And it's important because if we wanted to numb up all of these teeth from here to the midline, we're going to need to understand how this mental foramen works. Up next is the hyoid bone. This is number 8 down here. The hyoid bone is a really cool bone. I always like to tell my patients about it and impress them. But it's a horseshoe-shaped bone that lies below the mandible between the chin and the thyroid cartilage. It's the only bone in the body that doesn't articulate with any other bones. It's just held up by tissue and muscle. It appears as a floating, because it doesn't articulate with anything, of course, it appears as a floating curved radiopacity at or below the inferior border of the body of the mandible. We don't see it on our intraoral images, thank goodness, but it is there below the mandible. The term hyoid is actually derived from the Greek hyoides, which means shaped like the letter upsilon. I'm not sure what upsilon looks like, but I'm guessing it looks somewhat like the hyoid bone. The mental ridge we talked about in our intraoral anatomy, but it is a linear prominence of cortical bone located on the external or the outside surface of the anterior portion of the mandible that extends from the premolar region to the midline. It is the beginning of the chin, so it starts here and it comes all the way up to the chin. This ridge, it's number 9 right here, so it's actually higher than where I drew it, but That number 9 is the bony part of your chin, and it starts in the premolar and it comes all the way up to the midline. And it appears as a radiopaque band because it's made of bone that extends from the mandibular premolar region to the incisor region. So the mental ridge is the bony part of our chin, right? It starts all the way on the side and it comes to the center. You can see it on your intraoral images, which we have talked about, but a ridge, right, meaning a prominence of bone that works in a line, okay? So keep that in mind. Mental ridge is mental. Anytime we see mental, we're talking about the chin area, and a ridge being, a linear prominence of bone. The mental fossa, of course, then is number 10 here. You can see right above the mental ridge, and it is a scooped out, depressed area of bone located on the external surface of the anterior mandible above the mental ridge in the mandibular incisor region. It appears as a radiolucent area, this whole area up here will appear as a radiolucent area above the mental ridge. You can also see it on your intraoral images, and it's just the little part of bone that's not as thick as the chin, right? It's the part right above your chin where your bone is a little bit, I would say thinner, but the bone itself isn't thinner. It's just not as thick a structure. Yeah, so it's the part right above the chin. So it's not as dense, so it is just a little bit more radiolucent. And so that's what's telling us with fossa is that it's a depression. And then the lingual foramen, which we talked about in our intraoral images, is a tiny opening or hole, anytime we see foramen, located in the bone on the internal surface of the mandible near the midline. I wonder if your book has that picture. No, that really cool picture where you see the bottom of the mandible and it's got like all the genial tubercles and the lingual foramen. I love that picture. So it appears on your radiograph as a small radiolucent dot located inferior to the apices of the mandibular incisors. You can see it on intraoral images. Now, you won't see this on every single panoramic you take, right? Sometimes there'll be a little bit of variation. Maybe they're not in the focal trough perfectly or they're shaped funny. And so you won't see this perfect little dot the way you do here for number 11, but sometimes you will. And so you need to understand that this perfect little dot located right below the mental ridge and surrounded by the genial tubercles, which is going to be that white band right around it, that little dot, the little radiolucent hole, that is the lingual foramen. So then, of course, the next one is the genial tubercles, and they surround the lingual foramen. That's number 12 right here. They are tiny bumps of bone that are located on the lingual aspect of the mandible. They're very happy. They're like happy little surfers because genial means happy, right? And tubercle is like tubular. So anyway, they appear as a ring-shaped radiopacity surrounded by the lingual foramen. You can also see them on your intraoral images when you take periapical images of the mandibular anterior teeth. And the genial tubercles are these little bumps of bone where the geniohyoid and the genioglosseal muscles attach. So they're very important little attachment sites for muscles. The inferior border of the mandible, I feel like, is one of the easiest anatomic structures. Never really forget what that one is. And it is a thick linear prominence of cortical bone that defines the lower border of the mandible. It's the line, the bottom of the mandible. It appears as a dense radiopaque band that outlines the lower border of the mandible. You can also see it on your intraoral images as well. On this picture down here, it is number 13, pointing to the very bottom of the mandible. Mylohyoid ridge. That's just a fun word to say. If you haven't practiced saying this word out loud, you need to try it because the way it makes your mouth move is really fun. So it's mylohyoid ridge. It is a linear prominence of bone located on the internal surface of the mandible that extends from the third molar region downward and forward toward the apical area of the premolars. So it is on this little thing here. It's number 14. It starts near the third molar region, sorry, and it extends all the way down toward the premolars. You can also see it on your intraoral images as well, but it's going to appear as a dense radiopaque band. Sometimes it's going to be kind of confused with the external oblique ridge. So don't get those two confused. The mylohyoid ridge is the ridge that appears on the inside, on the lingual surface, okay? So number 15 here is the internal oblique ridge. It is a linear prominence of bone located on the internal surface of the mandible that extends downward and forward from the ramus. It appears as a dense radiopaque band that extends downward and forward from the radius. It can also be viewed on intraoral images. This one too can really get confused with the mylohyoid ridge. So be careful. This whole little section right here, it's important to know which one is the mylohyoid, which one is the internal, and which one is the external. Okay, so this area right here is going to be your mylohyoid ridge. This one is going to be your internal oblique ridge, and the top, the back one, that one is going to be the external oblique ridge. Okay. So then the external oblique ridge appears as a linear prominence of bone located on the external surface of the mandible that extends downward and forward from the ramus to the molar region. It appears as a dense radiopaque band that extends downward and forward from the ramus to the molar region. Okay, that's as far as it goes. We don't talk about it in the anterior area. We only talk about it at the ramus all the way up to the molar region. And you can see it on your intraoral images as well. The angle of the mandible is actually not one of the numbers that's on here. We already finished with number 16, which was the external oblique ridge, but the angle of the mandible is this jaw line right here, right? Like you picture like a nice square jaw. The angle of the mandible is this little back part right here. And if you look on page 357 in your book, you'll see that panoramic image on the bottom, the figure 29-8, that number 4 is actually pointing at the angle of the angle of the mandible. Woohoo, we finished bony anatomy, and so now we are moving on to the air spaces seen on our panoramic images. I'm not sure what it is about these 3 words, but they are really difficult for me to remember. I was in hygiene school thinking that these were the hardest words in the world to remember, and I didn't understand why I needed to know them so bad. But when our patients look at their panos, their panoramic images, they're going to see these big dark smudges covering half of their face, and they're going to be like, oh my God, what's that? And so you're going to really knock their socks off when you say, oh, that is your palatoglossial airspace. Like you got this, okay? So we're just going to break these down by where they are. So the airspace between the palate and the tongue is going to be the palatoglossial, right? Palatoglossial. And it's easy to remember because the palate is palato and glossial means tongue, right? We all know that. So the airspace between, let me draw on this, the airspace between the palate and the tongue is going to be number 1, which is the palatoglossial airspace. Number 2 is the nasopharyngeal airspace. So whenever I think of the pharynx, I think of like the back of the throat, right? And so the nasopharyngeal is the back of the throat. So this airspace right here, I drew all over it. I'm sorry. Let's get rid of those. The so between the nose and the throat is going to be this space, number 2. And it is the airspace in the pharynx that's located posterior to the nasal cavity. Then we have the glossopharyngeal airspace. And this one is the airspace of the pharynx that's located posterior to the tongue and the oral cavity. So that's this one, right? If my tongue is here, my tongue is lower, obviously, than the nose, then the glossopharyngeal airspace is this number 3, okay? So think about it like that. The one airspace, the palatoglossial, will be between the palate and the tongue. The nasopharyngeal is going to be between the nose and the throat, and the glossopharyngeal is going to be between the tongue and the throat. Here's this image again, and for you, you can see this image in your book, and you can refer back to it on page 358. It's figure 29-10. You can see the palatoglossial, the nasopharyngeal, and the glossopharyngeal air spaces. All right, so next up is soft tissue. We're almost done, so we can make it. So the soft tissue on a panoramic image there's only four that we really have to worry about, okay? It's going to be the tongue, the soft palate with the uvula, the lip line, and the ear. We're going to see what each one of these, where each one of these is on a panoramic. So number one, this one is the tongue, this airspace right here. And it is shaped like this because the patient should be putting their tongue to the roof of their mouth, right? Number two is the soft palate and the uvula, which I'm sure you can imagine like the soft palate's going to be up here by the palate, right? Uh, and then the uvula too, you'll see it'll be like a little bit of a darker structure in the back, right? Because everything that's at the back of the throat is going to be back here, right? Because this is the spine right along the back side. Anyway, number three is going to be the lip line. This one's pretty easy to get, right? The lip line because they're going to close their lips around the bite stick. And then number four is going to be the ear. Of course, the ear is going to be over here covering up the external auditory meatus. It's going to be covering up all of this space because this is the actual opening of the ear. So then the ear soft tissue, comes down here. I'm terrible at drawing with this mouse. All right, that's it for this chapter as far as the anatomic structures that I need to tell you. I would definitely recommend that you peruse through this chapter and you look at each one of those because they have a lot of the actual panoramic images in the book here, and each one of them has little arrows pointing to all of the different things. And so I would highly, highly, highly recommend that you take a minute and just kind of look at the number, see what structure that is, and see what it looks like on a radiograph, right? Because we talked about it. We said, radiolucency, radiopacity, things like that. But until you see it on a radiograph, you're not going to know exactly what it is. And you're going to see a lot of variation in each of these radiographs because they're all a little different. Some people have more teeth, some people have less teeth, some people have better contrast on them, some people got in the focal trough better. Sometimes there are structures that you're able to see on one that you can't see at the other, and that's okay. So definitely, definitely, definitely go through your book, look at those panoramic images, the actual radiographs, and see what these structures look like on, uh, on those radiographs.